Hello, my name is Lodewijk Brand, and I'm a fourth-year PhD candidate at the Colorado School of Mines in the Mines at Mines lab. This work was performed jointly with Lauren Zoe Baker and our advisor, Dr. Hua Wang. Today, I'm going to present a multi-instance support vector machine with incomplete data for clinical outcome prediction of COVID-19. What to expect? So we're going to begin with a little context talking about the COVID-19 pandemic. We will then motivate solving this problem by identifying some challenges in dealing with ICU clinical data. We will use these challenges to design our objective, the simultaneous imputation multi-instance support vector machine, and I will present how we optimize this particular objective. Then we end with our results. So the COVID-19 pandemic has had a significant impact on all of our lives for the past year and a half. It is currently still raging across the world. This has given rise to a wide array of research studying how can we handle and manage this pandemic. In our work, we take two perspectives on this approach. First, we're interested in the clinical perspective. So can we identify biomarkers or features that are predictive of serious COVID-19 outcomes? To do this, can we design some algorithm and interpret the results of the learned model to identify features that may be predictive of a serious outcome? Using this learned information, we could design clinical protocols to help allocate limited resources in high-stress environments. From the machine learning perspective, can we design novel algorithms and optimization schemes that can operate on time series data collected in a hospital setting that may contain missing entries? This will help us identify additional hypotheses beyond just the COVID-19 clinical outcome prediction problem and to other problems. So a big challenge when dealing with ICU data is there is an inconsistent number of records. For example, a patient that has been in the hospital for 2 weeks will have significantly more clinical data available to them than a patient that has entered the hospital 2 hours ago. In many standard machine learning approaches, these records are collapsed into a single record, into a single vector. This vector is then fed into a machine learning algorithm that then makes some prediction. In our work, we're interested in handling these records as they are, so that we could predict that an earlier record, so a record collected early on in a hospital stay, may give us insights into whether a patient may need serious care. A second challenge is that these records will often contain many missing entries. This is due to the physical constraints of the caregiver. When the patient enters the hospital, there's only so many blood tests that you can do in a single time period that may not capture the entire state of a particular patient. Then at a later time, we may be able to collect different measurements, but overall, each of these records, each of these instances are very incomplete. I'd like to note here that the final record is really where the determination of survived or died due to COVID-19 is determined. But in handling this data as not as a collapsed single vector, and instead handling it as a bag of records, may allow us to identify earlier on in the progression of COVID-19 whether or not this patient will have a serious reaction. In order to do this, we develop a machine learning algorithm by way of an objective. We follow standard notation techniques where scalars are represented by lowercase letters, vectors by bold lowercase letters, and matrices by bold uppercase letters. Given a matrix M, its ith row and jth column are denoted by M superscript I and M subscript J. The row and column blocks of M are similarly denoted. The trace norm of the matrix B is defined as the sum of singular values of that matrix B. The L1 norm of the matrix X is the sum of the absolute value of its entries. In order to handle the inconsistent number of records problem, we formulate our classification as a multi-instance learning problem. So given P patients, each represented by a matrix that holds n on subscript P instances and associated clinical outcomes from our training data set, we're interested in learning capital K hyperplanes and capital K intercepts by optimizing the multi-instance support vector machine proposed by Andrew Zidell, where C is a hyperparameter and our classification loss is represented by the hinge loss function. To handle the missing data problem, we focus on low rank matrix recovery. So given some matrix with missing entries, which we take as the horizontal concatenation of all of the bags associated with our data, we would like to learn some low rank matrix, which the assumption is that there is some structure across our cohort that we can leverage to fill in those missing data points. Our matrix with missing entries may also have corruptions, which we try and learn or represent by a sparse corruption matrix S. We do this by optimizing the following objective, where beta is a hyperparameter that balances between the sparse corruption matrix and the low rank representation. We want to leverage both of these tasks simultaneously. That is to say that given some data set that may have missing data, so this is clinical data, we want to impute all of that missing data across the labeled and unlabeled data points within our data set. And to do this, we optimize the multi-instance support vector machine with the low-rank imputation method. What this does is this allows the labels in our training data set to guide the imputation process, and for the imputation process to guide the classification. In order to solve this problem, since it is coupled across multiple predictors, we utilize the alternating direction method of multipliers to decouple this larger problem into a collection of smaller parts that are easier to solve. We provide the algorithm derivation details in our paper. We test our method on 375 COVID-19 cases from the Tongji Hospital in Wuhan, China, introduced in a recent Nature paper. Patients without clinical time steps are removed, and the remaining data are normalized via feature, and a missing data mask is calculated for each patient. The final data set contains 73 dynamic features across an average of around 17 observations per patient, for a total of 361 patients, of which approximately half survived and the other half died. The proportion of missing data in our data set is 87.6. For methods that we compare against that do not impute missing data, we perform a last observation carried forward strategy, which is used in that Nature paper. Here are the metrics that we compare our approach against: precision, recall, F1 score, and accuracy. We compare our method against k-nearest neighbors, 2 decision tree algorithms, support vector machine with kernel, and the multi-instance SVM and the simultaneous multi-instance SVM proposed in this work. We can see from this table that our approach improves the precision, F1 score, and accuracy results in the first 24 hours of patient admission, indicating that our method can accurately predict from this data set. In addition, we run another experiment where we restrict the amount of data available on a bi-hourly basis. What this means is that we'll train an algorithm using all of the available training data. And then during testing, we provide just the records that fall within an elapsed period of time from entry. We can see on the left-hand side of both of these figures, particularly in the precision side, on the left-hand side, that the two multi-instance learning methods improve the prediction performance early on in the ICU stay. This gives evidence that the multi-instance learning approach proposed may be useful in predicting COVID-19 outcomes. In addition, we investigate the absolute row sum of the predictors in W to rank biomarkers across two different age groups, from 33 to 64 years and 65 years plus. We find that bilirubin, neutrophils, direct bilirubin, and others are predictive of a serious COVID-19 outcome. This finding is supported by these works, and more details can be found in our paper. Thank you very much for listening. This work was done with me, Lodewijk Brand, Zoe Baker, and Dr. Hua Wang. In order to find our code and data, please visit this link on GitHub, and if you have any additional questions, feel free to contact me or Dr. Wang at these emails. Thank you very much.